You see, it's a minimal procedure. You do not drain. You just insert the balloon. You have to find the break, and only if you buckle it well, it will reattach. A 3-quadrant detachment. And what is new with the balloon operation, there is the suture not needed, which can perforate, and the buckle is removed after 1 week. We know by our animal experiments that after 1 week, the scar is already strong. And what is the advantage not using a buckle? I cannot see the audience there. Hello. There will be no diplopia, and there will be no buccal infection. Now, what's going on? We localize on unopened conjunctiva, as you saw it before, the break, and we do, in addition, 2 marks towards the ora serrata, towards the limbus, that we know in which radian the balloon catheter has to go. And here, after surgery, the balloon catheter is fixated at the side of the nose and at the front, and at the surgery, at the end of surgery, the balloon is indenting, not sutured on, compressed by the bony orbit and by the sclera, and the retina is still detached, and hopefully the detached break is floating on top of the buckle. And now let's see whether we are successful. It is only working if the hole is buckled correctly by the balloon. Here the deflated balloon, and here the balloon inflated with a balloon. And this is a detachment we treat. We localize the break transconjunctival, mark, as I showed you before, the hole on conjunctiva. At that moment of freezing, conjunctiva is fixed to the sclera. We make 2 additional marks to determine the radian of the catheter. We measure it. The hole is 14 millimeters from the limbus, as you see here. And during the surgery, the balloon is compressed, not sutured on. We open conjunctiva just for 1 millimeter. And then I show you the balloon. We inflate it with 1 milliliter sterile water to see, and you see in addition these marks, they are 10 millimeters from the center of the balloon, 15, 20 millimeters, so we know how much posterior our balloon is positioned. We take out the syringe. The balloon catheter is flexible like an overcooked spaghetti. We put in a metal stylet to make it stiff. We measure now the 14 millimeters to show you. So that means the 3rd black mark has to be at the limbus, so we know how posteriorly the balloon is moved. We take out the stylet because now we want to inject the sterile water. We insert a syringe with an adapter. We inject at first 0.5 milliliter of fluid. And what do you have to do? You have to check, as with segmental buckling, to see whether the retina has a pulsating disc, whether it's a perfusion present. That is the case. We inject more, up to 1 milliliter, as you see here. And we check again whether the central artery is pulsating. Here is an animation. You guess that the balloon is coming beneath the detached break. And that's the end of the operation. You take off the syringe. You leave the adapter on. We put 2 traction sutures. If you do the surgery in topical anesthesia, you don't put traction sutures. The patient looks in the direction you want. And then you remove the speculum. Be careful, the balloon is not yet indenting. It will be displaced. Very careful, remove the speculum. And that's the end of surgery. At the end of surgery, the balloon is compressed between bony orbit and sclera. You fixate the catheter at the side of the nose, as I mentioned before, and afterwards we fixate the adapter on the front. And if the next morning you want to have a larger buckle, you just inject via the adapter a little bit of fluid and you have a larger buckle. Hopefully not needed. You put ointment in and you double patch the patient after surgery. When the next morning the retina is attached under the premise you didn't overlook a break and the balloon was positioned correctly beneath the still detached break, you unpatch one eye, and that is all what has to be done. That's after surgery the next day when it is attached. You see the cryo marks, and we added laser marks. After 7 days, they are pigmented. We withdraw the balloon, and that was the procedure we did. It takes only a short time, and I would say that's it. That's after surgery. And here you see again the balloon is deeply indenting. The next day, the retina is hopefully and luckily attached. And it works if no break is missed, and if the position of the balloon is correctly beneath the break. The detachment only is sustained if the hole is sufficiently surrounded by laser or cryo marks. And when can you use a balloon? For a detachment with one break or with a group of breaks between 1 clock hour. And here a small detachment, easy. Why? Because there's not much space, you can overlook a break. It's easy localization. And after 1 week, the balloon is removed. You see only the scar. And here a detachment after some days with the same hole. It's larger. Do you have to do more? No. The cause is, as you remember the speeches before, it's just the break. The break is buckled, and after the balloon is removed, you only see around the break the scars. And here, the balloon is helpful when there is the hole at 9 o'clock at the rectus muscle. Of course, as long as the balloon is present, there is a diplopia. However, if the balloon is removed, the binocular vision is back again, and you only see the hole surrounded by marks. And now you would like to know what's the results. Here are 500 detachments we operated. After 1 balloon operation, the retina was attached in 93%. Within 6 months postoperatively, 2% redetached. After 1 reoperation, 98% were attached, and only 4 eyes had 2 reoperations. The retina was attached in 99% during a follow-up of 2.5 years. And that is all what I wanted to tell you, and now I think we can continue to discuss if there are still questions. Yes, we still can afford it. That was a quick run through, but we decided to show it to you. Do we have a question? Yeah. There is a lady, your name and the country, please.
Fatima Qasim from Qatar.
Sudan.
Qatar. We're lit cup country. I wanted to ask, in the failed cases, it's such a wonderful technique. What did you do? Again, a sponge, or you went for vitrectomy? If the balloon fails?
What?
If the balloon fails, what's your next step?
You find the break. Our regimen was then to do a buckle, a sponge, but you could do as well a balloon. However, when you deflate the balloon, the indentation remains 18 hours because the balloon would again go in the wrong position. If you have found another break, or the break was not ballooned correctly, you can then, after 18 hours, insert the balloon again. But in our series of 500 patients, we use the sponge.
Yeah, this is Prabhu from India.
More questions?
Yeah, are there any chances that the balloon can slip inside from its position?
Can the balloon move within the first couple of minutes or hours?
How do you titrate how much fluid to
minutes
insert?
and few hours, we found it out. It's still not deep indenting. It is deep indenting in the moment when you have inserted the balloon. The eye pressure, as you assume, is elevated. The eye is something mobile, dynamic. The moment the eye pressure is normal, the balloon expands, and then it has a deep indentation, and the next morning you say, my God, it should be a little bit more to the right. I take out the fluid, move the balloon, and if you inject, it jumps back into the indentation. You have to wait 18 hours.
Professor,
that was the time we determined.
Yeah, Professor Kreissig, Mudit Tyagi from India. So since sponges tend to expand over a period of time after we put it, does it make sense for us to do a paracentesis in every case to ensure that there is some hypotony? Otherwise, the central retinal artery pressure will rise. So should we do a paracentesis in all cases of sponges because they expand?
If you talk parallel, I don't understand this gentleman. Forgive me. Come closer. They are just talking.
Yeah. No, my question is that for sponges, should we also do a paracentesis every single time? Because sponges expand, so it will lead to a pressure rise subsequently. So do we do a paracentesis in every case of sponge, or we don't need to do that?
You see, the difference to the sponge is the balloon expands and impresses in their eye because their eye pressure gets normal and low, and then he can make an indentation in the sclera.
No, my question is for sponges. When we do...
I cannot understand him, sorry.
Yeah.
Why don't you answer?
So he's asking for sponges.
Yeah?
Do you do paracentesis in
No, I never do paracentesis. Sorry to ask you that I could listen. I never do a paracentesis. If I found after a sponge the pressure is elevated, I take my forceps, I close them, and I push the sponge back under the suture. I wait some hours, not hours, I wait some minutes, and the eye pressure gets normal. You see it by the pulsation of the central artery. No, I don't drain, no.
Okay. Thank
Would
you.
make the thing too complicated.
Yeah.
Thank you.